Can we just pop my slide up that depicts our sort of algorithm at UCLH in terms of managing pancreatic fluid collections? So the first question, is the lesion symptomatic or not? If not, except for very strange circumstances, you may choose to observe. If they are symptomatic, and in the case of walled-off necrosis, the prescient point is of infection, almost always. So if you've got walled-off necrosis, the difference between those two definitions is whether there is solid material in the lesion, and by definition, by the Atlanta criteria, the lesion is more than 4 weeks old. We can talk about timing of drainage shortly. So the lesions are 4 weeks old. If there is no solid debris, it's a pseudocyst. I think the evidence still favours plastic pigtails, although I think internationally and certainly in the UK, we're seeing lambs inserted into pseudocysts very, very frequently because it's so quick and easy. You can be done without fluoroscopy, etc. I think in the case of potential disconnected duct syndrome, there is an advantage to plastic pigtails such that the pigtails can lay in for up to a year. You take the lambs out too early in a pseudocyst, you can get recurrence if there is a disconnected duct in the tail. Into the walled-off necrotic collection, as seen in these two cases. First of all, and again, back to our MDT, is EUS drainage possible? Very often that's not the case. So if you've got fluid and fat necrosis down the paracolic gutters into pelvis, you may be stuck with percutaneous drainage, and then it's a case of upsizing drains, etc. If it is possible, and very often it is, adjacent to duodenum or most commonly the stomach, then you want to be placing a LAMS. I think there's data on that's pretty convincing above pigtails now. What LAMS? Well, frankly, the bigger the better. If you've got lots of necrosis, I would favour a 20, certainly from the stomach, if not a 15mm LAMS. And it would be my practice to always leave plastic pigtails across to prevent necrotic debris blocking that stent and the patient presenting with sepsis very quickly. If the patient is frankly septic, inotropes, etc., I would favour the early use of nasocystic drainage for irrigation. I would not do that routinely. Others may argue with that. And when do we do a necrosectomy? Seldom would we do that in the index drainage procedure. Others do, I know that. We tend not to. It's amazing how you can avoid any necrosectomy at all with large LAMS, particularly the 20. But if the patient grumbles with sepsis or if there is ongoing failure to thrive, then a necrosectomy may be required. So once that's done, we do a 4-week CT. If there's adequate resolution, the LAMS can come out. I think the great debate is if there is inadequate resolution, what is the plan then? So Manu Nayar in Freeman has put together a UK series, retrospective, but there's about 1,018 patients across the UK undergoing pancreatic fluid collection with LAMS. And what this real-world data showed us is that the adverse event profile was excellent, 3.4% immediate, 6.6 delayed adverse events, but the length of indwelling of the LAMS did not correlate with delayed adverse events like bleeding and buried stent syndrome, which is very good. Furthermore, the median time for these LAMS being present was 7 weeks, way beyond what the early Florida data told us we should be doing. And in fact, 80% had the LAMS removed beyond 4 weeks. So I think that tells us, and this probably needs randomised data and get into guidance, and Marco's and John's comments will be welcome. But I think if there is ongoing sepsis, necrosis, still a large lesion, then we can leave those LAMS somewhat longer. If we're concerned on that CT that there is a bit of buried bumper or there's a vessel nearby, then potentially we take the SEMS out at that point and just put some pigtails across the defect. So John, what do you think?
Yeah, I think you've summarised very well the sort of the clinical problems that we see and given a very clear sort of guide as to how we manage these patients. And I think we follow what you've laid out. I think you're right that the anxiety from our point of view, especially in the tertiary centre, has been patients come across for an intervention and then you may lose them to follow up. Sometimes these patients can have chaotic lifestyles, and that can sort of feed into then the ability to get them back to have the LAMS out. So it's reassuring to know that there are data to suggest that it can be left for longer than the sort of month to 6 weeks that we'd initially sort of felt it needed to be removed in.
Marco, can we move a little bit on to the question of necrosectomy? I showed very briefly there, tugging at stuff, using snares. We sometimes use Roth nets, and it's fair to say, it was certainly in our practice, we're not quite sure what we should be doing. Be interested to know your practice and also a new technique that we actually discussed yesterday in the esophageal section, the Endo-Rotor. where your experience of that and where you see that sit. So do you have a very clear idea, a clear algorithm in your mind as to the technologies and techniques we should use for endoscopic necrosectomy?
Yeah, again, that's a kind of an issue where, as an endoscopist, if you have to do a case with a patient with a lot of necrosis and you can use only the conventional devices, it's a tedious job, and you can spend more than an hour or 2 hours trying to get material out, and sometimes then even after spending that much time, you're frustrated about how much you are able to kind of clean out the cyst. So we have been working in the past few years on this Endo-Roto technique, which indeed evolved from indication to treat Barrett's. And we have been mainly now having gained experience with the smaller catheter, which in our series, and we published that already, performed quite well, better than the conventional devices. But now we have a new device, which is even bigger, which really is able, with a kind of circulating knife and with negative pressure, to kind of suck in the necrosis. And instead of only the very soft type of material that you can then kind of get out, also the more sticky material, which I think is important. And I'm a firm believer of when you set the indication to treat a patient with infected necrosis, do necrosectomy, you have to do it well. You have to spend time and you have to clean out as much of the necrosis as possible. And if you are not satisfied after the procedure, you have to reschedule the patient within 2 days. It doesn't mean anything, to wait another week, because it needs to clean. And I've seen cases where we follow this approach. These patients then have a miraculous recovery. If visually you kind of clean out the cyst, you're happy with that as an endoscopist, the patient will do much better, much, much better. So that should be the aim of necrosectomy. And we have to prove it, but I'm quite certain that this new Endo-Roto device will help us as an additional tool to achieve this.
Great. Marco, would you do a necrosectomy at the index EUS when the lambs goes in?
No, I'm not so happy with doing that because these patients are quite sick. And then I rather, deal with the first procedure of doing the drainage. Some patients, about 20 to up to 35%, already do a lot better only by doing the drainage procedure, by having pus draining into the stomach. And then at the second occasion, when hopefully the patient has recovered a little bit from his kind of sepsis, but also when the tract has a little bit matured, because I would also be a little bit afraid of, a lot of pus going into the abdomen and kind of contributing to the sepsis and the kind of the SIRS reaction. So that's not our approach normally. We would first do the drainage and then go in, usually after 48 hours.
Okay. We'll fascinating discussion. We're going to move on to the next case, but in doing en route to that, we'll just show a very brief video showing the role of Endo-Roto in pancreatic necrosectomy.